Scabies was added to the list, the official list at the WHO of neglected tropical diseases about 4 years ago now. I think it's safe to say it is a very neglected issue. Some of you may be surprised to hear there are upwards of 200 million infections a year, and those infections carry many of the associated issues such as stigma, comorbidities, access to treatment, lots of the issues which are kind of pervasive among other NTDs as well. So a framework, a paper describing this framework for the control of scabies was published quite recently in PLOS NTDs. As you can imagine, a hugely collaborative effort with contributions from across universities across the world, from the UK, Australia, Senegal, Japan, Liberia, Philippines, just to name a few, but also at a higher, more official level from WHO Geneva, and also many of the regional offices across Western Pacific, Europe, Africa, and so forth. And it's our huge pleasure today to welcome Dr. Michael Marks to represent kind of this large body of collaborative work and also give us an introduction to scabies. For those who are kind of familiar with this sphere and in fact neglected tropical diseases as a whole, I think, Michael, you wouldn't need an introduction. Perhaps for those who are slightly new to the some of these topics that we'll be discussing today, I'll just remind everyone, Dr. Michael Marks, you are Associate Professor at the London School of Hygiene and Tropical Medicine. You're also an honorary consultant at the Hospital for Tropical Diseases here in London. And of relevance for today's talk particularly, you're also Vice Chair of the International Alliance for the Control of Scabies. So Michael, thank you for your time today. A very warm welcome. I hope you're doing well.
Yeah, thanks so much for the invitation.
Thanks so much for joining us.
Thank you very much, everyone, for joining and for the invitation to speak. So, as Marion mentioned, my name is Michael Marks. I'm an epidemiologist at the London School of Hygiene and Tropical Medicine, and I am the current Vice Chair of the International Alliance for the Control of Scabies, which is an organisation bringing together academics and other partners with a sort of shared interest in the global agenda of scabies control. So just outlining what I'm going to talk about today, I'm going to cover two pieces of, or two sections, a background, a sort of introduction to the concept of scabies as a public health problem. I'm sure that everyone is familiar with the idea of scabies as an individual unpleasant skin condition, but really moving from that idea of the individual to the population level, and reviewing some of the epidemiology and the data around potential control strategies, and then moving on to the sort of components that are making up the proposed new framework for scabies control moving forward. And this is obviously situated by and in and informed by the new NTD roadmap for 2021 to 2030, and a number of other developments in diagnostics and medicines that have led on to this WHO informal consultation and eventual proposed framework. So starting just with a brief introduction to the concept of scabies as a public health problem. I'm sure that you are all familiar, or I hope many of you are familiar with the idea that scabies is caused by transmission of a parasitic mite, and really in highly endemic settings, transmission is almost exclusively human-to-human transmission by prolonged skin-to-skin contact. And on the left, you can see a female mite moving around slowly, and the life cycle is that the mites burrow under the skin, the male and the females mate. The female will lay eggs, which will hatch over a period of time before maturing, and then the cycle will continue. And that's important because itch, which we think of as one of the major features of scabies, is not actually caused by the mites themselves, but by their excreta and their eggs. So people often don't become itchy immediately upon infection, but it takes some time. and secondly because the drugs that we have available to treat scabies are differentially effective at different stages of the life cycle, and at the moment at least that has important implications for control strategies. So we want to think about why people should care about scabies as a neglected tropical disease and why it matters. And this is a schema from a paper that IACS and partners published in Lancet in 2019, really trying to lay this pathway out. So we have, on the left-hand side, the primary effects of scabies itself. So it causes skin lesions, which are stigmatizing and are very itchy. And that results in stigma, social isolation, sleep disturbance, and associated with absenteeism from education, economic effects. So many of the sort of primary manifestations that we see with a number of the neglected tropical diseases. So this is a disease here with significant morbidity, and it's morbidity that is reaching out beyond the direct health sphere into other aspects of people's mental well-being and their educational and financial well-being. And that, I think, in and of itself is something that warrants intervention. But really for scabies, because infestation with scabies results in breach of skin barrier function and modulation of the local host immune response, there are a number of downstream sequelae that follow from the initial infestation. And most importantly, there is a significantly increased risk of impetigo, or pyoderma as it's sometimes referred to. So these are superficial skin infections, most commonly caused by Streptococcus pyogenes and Staphylococcus aureus. And you can see here typical examples of someone who's got secondarily infected scabies lesions. And in many parts of the world, scabies is one of the, if not the, predominant driver of impetigo. And through this is adding additional morbidity, health impact, requirement for additional treatment. And so this is a sort of super added impact beyond the direct effects of scabies itself. And then moving on from that further, through this increased risk of skin and soft tissue infections, patients are at a higher rate of more serious infections. So previously I've shown just impetigo, these are superficial infections, but we know that those in and of themselves predispose to more severe skin and soft tissue infections, such as cellulitis or necrotizing fasciitis, to bloodstream infections with Streptococcus and with Staphylococcus, which have high mortality rates. And Streptococcus pyogenes is associated with a number of downstream immune-mediated complications. So these are caused by an abnormal host immune response to the bacteria, which can result in kidney damage, resulting in chronic renal failure, and can contribute, we believe, to rheumatic fever, leading on to rheumatic heart disease. And both of these diseases, rheumatic heart disease and chronic kidney disease, have considerable mortality rates per year and a huge economic cost of treatment. So really we see a spectrum of effects for scabies, varying from the direct manifestations of the scabies infestation itself through to the secondary effects of additional bacterial superadded infection, and through to the downstream consequences of those. And these are really quite significant. There are estimated to be several 100,000 deaths a year from rheumatic heart disease. So even if scabies is only contributing to a small proportion of those, that is a significant mortality impact, as well as its considerable morbidity impact. And we know that scabies has an extremely high prevalence in many countries, but really compared to a number of the other neglected tropical diseases, you'll see that data remains very limited. So this map shows a range of countries where reasonable quality prevalence surveys have been undertaken. And if I draw your eye in the first instance to the bottom right corner, you'll see that a number of the Pacific Island countries, so the Solomon Islands, Vanuatu, Fiji, Timor-Leste, for example, they all report general population prevalences of more than 20%. So these are extremely high prevalences in children, really. You know, 1 in 4, 1 in 5, often in these contexts, having scabies infestation, and can be higher in the highest risk groups. And you'll see that similarly high rates of infestation have been reported in a number of countries, several parts of Latin America, and across Africa. But really you see that there's a great dearth of information reflecting the fact that good quality prevalence data is lacking and is a clear programmatic need. Excuse me. I think the real sort of progress over the last 7 or 8 years has been in the development of community-based control strategies. And these will be familiar to many of you from other neglected tropical disease programs. So this is what we refer to as mass drug administration. And, you know, this has been a mainstay of programs for many NTDs, including trachoma, onchocerciasis, for example. And ivermectin is a highly effective anti-scabies drug. And so people, including our group and collaborators, have been undertaking a series of studies to understand how ivermectin-based mass drug administration can be used to control scabies. And I'll just take people through a bit of that data, but really the headline figures, you know, in studies are that in high prevalence settings, a single round of mass drug administration appears to be able to reduce the prevalence of scabies by up to 90%. And by reducing the rate of scabies, it also reduces the prevalence of these secondary bacterial infections. And I think that's a particularly important point, because it's reducing the burden of these bacterial infections without having to use antibiotics. So that is both good in terms of reducing our exposure to antibiotics, and it also shows that that relationship between scabies and impetigo is very clearly causal, because reducing scabies does translate truly to a reduction in impetigo. And I'm just going to highlight from 2 of the major studies. The first, which was a study called SHIFT, the Skin Health Intervention Fiji trial. And in SHIFT, 3 communities in Fiji were randomized to 3 different interventions. An ivermectin-based mass drug administration arm, permethrin, which is a topical anti-scabies treatment arm, and what the study team referred to as a standard arm. And I'll just explain a little bit about the standard arm, which will explain why the standard control arm seems to have such a profound effect. Because this was a trial, it was felt unethical in the context of the study to have a true control arm where people had the prevalence of scabies measured at baseline and again at 12 months and again at 24 months. It was felt not ethical to diagnose people with a treatable infectious disease and leave them just so you could see what happens. And so the standard arm in this study consisted of examining every single person in the community, diagnosing every person in the community who had scabies, providing them with a referral to their local health clinic, and ensuring that the local health clinic was already stocked with appropriate drugs. So I think we can all agree that that is probably quite distant from the actual reality of what would have happened if the study hadn't taken place, and probably explains why there was a reduction in the standard arm. Notwithstanding, there are several striking findings. You'll see that at baseline in this study, all of the communities had very high prevalences of scabies, between 30 and 40%. So this is an incredibly common condition in some of these communities in Fiji. And it's very clear that the ivermectin-based strategy is the most effective, reducing the prevalence of scabies from more than 30% to only 2% at 12 months. And no other interventions were delivered. So there were no environmental measures taken, no cleaning of bedclothes or personal clothes or possessions, which are often recommended, and no further mass drug administration was carried out. And despite that, you can see that the prevalence of scabies remained really low, 3.7% out to 24 months. And as I've mentioned, you can see here on the right that just by treating scabies, there was also a significant onward reduction in impetigo. So this was really the first study to establish ivermectin-based MDA as the standard of care, and we followed that with a larger study in the Solomon Islands involving 25,000 individuals, but where broadly you will see the findings are very similar. Scabies was very common at baseline, almost 1 in 5 individuals had scabies, and it fell to only 2% at 12 months. And again, no other interventions were delivered, and although you see a slow rebound up to just under 5% at 36 months, this means still 3 years after 1 round of MDA, the prevalence of scabies was still only about 20% of what it had been at baseline. So really demonstrating that high coverage MDA in areas with not much population movement can be highly effective. And again, we see a significant and sustained reduction in secondary bacterial infections. So really, those are some of the data that have underpinned this work in bringing together a framework for scabies control, which I am going to move on to now. So first of all, you can see this slide is slightly out of date because the WHO NTD roadmap is very much no longer in draft, but is published. And as Marion mentioned, scabies was one of the newly added NTDs since the last roadmap, and therefore for the first time there is indicators and targets for scabies included in this roadmap. And there are 2 major targets that have been adopted. The first is about countries incorporating a scabies management plan within the universal healthcare package, and you can see that this aims to scale up between 2020 and 2030 to reaching global coverage. And then a second goal, which is around the proportion of countries or the number of countries where MDA is rolled out as a control strategy for scabies. And obviously this is a lower number, both because this is a significantly larger undertaking, and also because there will be many countries where MDA would not be the appropriate strategy. And so this is really focused on those countries, such as those in the Pacific and in other parts of lower middle income country settings, where the prevalence is particularly high and where MDA is felt likely to be the appropriate strategy. And there are therefore a number of critical actions that are required around guidance and tools for mapping in endemic countries, guidance for the implementation of preventative chemotherapy, which is how WHO refers to MDA, and creating the advocacy and funding plans that are required to move this forward. So there have been a number of steps taken to drive this forward, one of which has been the development by IACS of consensus criteria for scabies diagnosis. And the idea here has been to standardize the way that health systems, particularly in lower middle income countries, evaluate and make a diagnosis of scabies so that we can begin to move towards standardized diagnostic criteria, standardized surveys, and standardized estimates, assessments of the impact of MDA. And so this has been a really useful development and is beginning to be taken up by many groups worldwide. And there is essentially a structure that ranges from suspected scabies all the way up to confirmed scabies, and a sort of recognition that confirmed scabies, the sort of highest level of specificity, is really designed for use in high income settings and in potentially drug trials, whereas the lower levels B and C are really what we anticipate being used in surveys by non-expert examiners in the field. And IACS has developed a series of tools to help people begin to convert these criteria into actions as part of this framework. Another really important step has been the addition of ivermectin to the WHO essential medicines list. Ivermectin already was on the WHO essential medicines list, but for different indications. So for example, for onchocerciasis and for lymphatic filariasis. But thanks to the work of colleagues at the International League for Dermatological Societies and the International Foundation for Dermatology, and we were able to get ivermectin added as a medicine for specifically the treatment of scabies. And that is important because that plays a role in allowing or assisting countries in accessing ivermectin for this specific indication, which differs from the indications that it has traditionally been used for in the context of MTD programs. And so coming towards the end of the sort of presentation component, all of these components which feed together into the development of a framework for scabies control. And so in 2019, the World Health Organization held the first informal consultation on a framework for scabies control. And this was held in Manila over a number of days and attended by experts from academia, from NTD programs, from the task force, from WHO regional and HQ offices, and really to try and move forward with some provisional steps, recognizing that there are still a large number of unknowns, and we are still trying to learn what the right approach will be in different settings, but giving us an initial framework that we can work within. And so we try to tackle these around those critical areas that the WHO roadmap had identified would be necessary to move forward for scabies control. And so on mapping, really an attempt to stratify this into a number of steps. So identifying potential areas for MDA, which might be based on pre-existing data or desk review, to at least prioritize which countries and which districts within countries were most suspected to have a higher burden of scabies and therefore should be targeted earlier. And really, the proposal is to use rapid clinical assessments using trained health workers, but clearly not dermatologists. So using simplified clinical case definitions based off the IACS criteria and limited exposure. So if you're diagnosing a patient with scabies in your clinic as an individual, it's really important to know absolutely for each person, do they have scabies, yes or no? And therefore, potentially examining their whole body is very important. But here we are trying to make decisions at the population level. So the precise diagnosis for each individual becomes less important than understanding, is the prevalence 2%, 5%, 15%? And secondly, of course, we want something that can actually be actioned and made operational. And so there's really been a lot of work done thinking about limited exposure examinations, by which we mean just examining the exposed limbs and the head and neck. And there have been a number of evaluations of that now conducted in both sub-Saharan Africa and the Pacific, showing that that remains a highly effective strategy, really very sensitive for picking up scabies. And based on the current data, the idea is to do community-based all-age surveys. And of course, there may be opportunities to consider other strategies like school-based surveys, but there's a recognition, at least for the moment in the framework, that most of the data is based on whole community-based evaluations. And so that's the idea of what do you need to do to get going, rapid mapping, and then we may want to embed some more accurate, more detailed prevalence surveys as part of our impact assessments. And these are important, for example, to do impact assessments through longitudinal monitoring, but also so that we can potentially get, where appropriate, age and gender specific disaggregated estimates of burden and impact, so that we can see that our programs, as we develop and roll them out, are reaching everyone equitably. So what about actually implementing MDA, which was the second of the critical actions that WHO identified? And the consensus in the provisional framework is that mass drug administration would be an appropriate strategy where the community prevalence is at least 10%. And I think everyone in the community acknowledges that this is somewhat an arbitrary threshold, but it was one at which experts felt that there was sufficient evidence for the use of MDA. And based on the data I've shown you, the current feeling is that this should be utilizing an ivermectin-based regime, currently using 2 doses of ivermectin 7 to 14 days apart, reflecting, as I mentioned, the fact that the drugs don't necessarily affect all components of the life cycle. And there are a number of ongoing studies which are close to reporting to see whether or not we could simplify this to a single dose of ivermectin, which would obviously at an operational level be extremely attractive. The feeling was that this should be implemented at a fairly high level, so the district level, and as with many programs, that's both because that's logistically easier, but also because there are risks that if you're treating on a very small level, you will get movement between treated and untreated communities, which may result in reintroduction of scabies into untreated areas. So the idea is to try and reduce that risk as much as possible. And we are aiming to treat as much of the population as possible. And the recommendation, at least in the provisional framework, is that we should be doing annual MDA for a certain number of rounds and continuing after that to evaluate the impact and stopping if the prevalence is below 2%. And just as with the 10% starting threshold, I think we all acknowledge that this 2% stopping threshold is arbitrary at the moment and requires further both empiric and other sources of data, health economic evaluations, really to understand how we will best move this forward. Where the prevalence is very clearly low, below 2%, the feeling was that the best strategy at the moment, for which there was the most evidence, was an intensified disease management strategy. So that's about ensuring high quality diagnosis at facilities, access to an appropriate scabicidal treatment, and appropriate treatment of patients' contacts to reduce their risk of reinfestation, and that this should be linked to and delivered through WHO's Universal Health Coverage Initiative, so making the treatment of scabies a key component of UHC. And I've identified here a number of the steps that will be required, so enhancing clinical care in primary health, developing appropriate guidelines, training, and improving the general quality of data collection. And then we have a sort of grey area at the moment, which is where the prevalence is more than 2%, so substantial, but below 10%, the threshold at which currently MDA is appropriate. And there's really felt to be limited data at the moment to guide a strategy here. And so there would be flexibility here for local actors to make decisions about what the appropriate strategy might be. And it may be in some settings that MDA was still considered a completely reasonable strategy in this context, because empirically it doesn't feel like there would be a significantly difference between 9%, for example, and 10%. But as with all of these things, you have to draw a line at some point, and the line currently has been drawn at 10%. I'm not going to go through all of these points now, but there are a number of key programmatic research issues that were identified, and they're outlined both in our paper in The Lancet in 2019 and in World Health Organization's report of the informal consultation. I'll just highlight a few of the very key ones, which include the fact that we need more studies to determine the impact of MDA and scabies control strategies outside of islands, and particular in urban settings, because scabies is relatively unusual amongst the NTDs in that it's also prevalent in urban settings. To better understand this relationship between scabies and impetigo, because that has big impacts on the sort of value added of treating scabies. To move forward in really defining these sampling methodologies for programs. And many of you may know that ivermectin is not currently used in children aged under 5 years or under 15 kilos, but there are a number of studies going on to investigate if it may be safe to do so, which would significantly simplify treatment regimes. So in conclusion, there have been really considerable progress on control strategies for scabies over the last few years, and it's very encouraging to see these targets in the new 2021 to 2030 NTD roadmap. But we really need ongoing operational research and partnerships with ministries of health to drive forward the control of scabies globally.